Okay, so today we're going to be talking about abdominal imaging for MRCP part 2. Yeah, let's get started. There are about 30 to 35 images that you should be familiar with. There are, of course, more images that could potentially come for the exam, but it's important to understand that these are the most commonly asked ones. Anything that comes out of this, it's definitely possible because there's no way to predict exactly what they will ask, but most of the times you will be able to figure out the diagnosis or the management from the clinical scenario itself, and the image will kind of just be a corroborative or supportive evidence for you. But these particular images, it's important that you identify because you may not be able to make a diagnosis without being able to uh, properly diagnose these images. So let's get started. First, let's go through X-rays. And the things that I want to go through initially are obstructions. Okay. So you can see that there are some dilated bowel loops here, multiple air fluid levels, and so you need to identify whether this is a small bowel or large bowel obstruction. Okay. So this is a small bowel obstructions, and you need to know why that is. First is multiple air fluid levels are usually seen in small bowel obstruction, and you see these little valvae convenientes. These are like they go all the way across from here all the way till here, and this is important because it will help you differentiate between small and large bowels. And you also need to know that they're kind of ubiquitous, like they are usually everywhere and not focal to a single area of the abdomen. Okay, so this is another obstruction. Now see if you can tell it apart from the previous x-ray and what is different in this. Okay, so this is a large bowel obstruction, and what you need to know is that you'll see these haustrations. And the thing about the haustrations is that they don't, either they'll be completely absent. Like you see this part of the bowel, you're not seeing any haustrations because it's so dilated. And you'll come to this part of the bowel, you'll see that they are there, but they don't go all the way across the lumen, right? It's just a little bit. So that usually points to a large bowel obstruction. And then you need to know that there are these different cutoffs for bowel obstruction. So small bowel obstruction, usually the dilatation is around 3 to 5 centimeters. Colonic obstruction is more than 6 centimeters, and the cecum can dilate up to 9 centimeters during an obstruction. Okay, so this is a very typical X-ray that you will get. You need to be able to identify it. It's a spot diagnosis. So this is a it's a volvulus, it's a sigmoid volvulus, and you see this coffee bean appearance, right? So this particular sort of thickening is the walls of both of these lumen coming together, and it forms a sort of thickened appearance. And so this is a sigmoid volvulus. You can also get a cecal volvulus. Cecal volvulus, they also look similar to a sigmoid volvulus, but this coffee bean appearance might not be as pronounced, but they do have this little like C shape, and they are usually present towards the center, and you can see the distal part of the large bowel also. Here, you can't really see the rest of the large bowel, right? Yeah. Okay. So once we've talked about obstructions, we need to talk about perforations. So perforations are fairly easy to come, make a diagnosis of. You'll see this air under the diaphragm, which is should be a telltale sign for you. You see the dome of the diaphragm. You see this black shadow underneath it, which is the air under the diaphragm. Okay. So what about this? What are you seeing in this? So essentially, this is the falciform sign. So you will see this falciform ligament that is prominent. And usually, what happens is because there is air under the diaphragm, it will seep into the peritoneal folds, and that will cause this to become hyper intense. And you can pick that up on an X-ray. So this falciform ligament sign is also a sign of intestinal perforation and pneumoperitoneum. This is a very sort of rare thing. It's difficult to pick up if you're not looking for it. Uh, it's most likely picked up by a radiologist, but it's some theoretical thing that you do need to know. So this is known as the Wriggler's sign, where there is air on both sides of the bowel wall, and it's usually seen when there is a fair amount of air in the peritoneum due to a perforation. Okay, so we've seen two signs so far: falciform ligament sign and Wriggler's sign. What about this? So this is a toxic megacolon, and it's something that you need to be very, very aware of when you have a history suggestive of ulcerative colitis or Crohn's disease. So if the history tells you anything like abdominal pain with bloody diarrhea, with some rashes, joint pains, and they give you this image, you should be thinking about toxic megacolon. So toxic megacolon, the treatment you need to know is that the initial line of treatment is oral corticosteroids, and if it's not getting relieved in around 24 to 48 hours, then you need to go for surgery. Okay, then a smaller but still significant part of this is knowing to pick up on renal calculi. You need to know a certain amount of details about the calculi. So there are four types of calculi that you should know: calcium oxalates, truvite, cysteine stones, and uric acid stones. And you need to know what are the characteristics of each of these stones, what kind of crystals they form, what is the urinary pH that they tend to get either precipitated by or relieved by. So that, of course, is not part of this. I just want to tell you that now that we're discussing it, these are things that you should know for the MRCP exam. So these are renal calculi. Sorry, this is a bad image, but it's supposed to show you a staghorn calculus. This is a large calculus that's taking the shape of the renal papillae. But I will get you a better picture of this. Oh, this is also a staghorn calculus, right? So you can see how it's taking like the renal papillae, the shape of it. So this is a staghorn calculus. It's usually caused by urease producing organism, mostly Proteus. Okay. So barium studies, these are probably the most annoying, but they're pretty easy if you know what you're looking for. Okay. Okay. Oh, sorry. So what is this? You have a dilated esophagus, which is ending in like a very thin line. So this is known as a bird beak appearance, which is commonly seen in achalasia cardia, where the lower esophageal sphincter cannot relax. Okay. And what is this? It's like a little jumbled esophagus, looks a little bit like a screw. So this is known as a corkscrew esophagus. It's seen in diffuse esophageal spasm. So this can present with dysphagia or painful odynophagia. Okay, so this is important. You need to know that there is this esophagus, and it comes and smoothly comes into this little obstruction like area, and then again it sort of dilates, and then you can see the diaphragm and the stomach. So this part seems normal, this part seems a little dilated, but what is this is what you need to know. So this kind of a smooth filling defect usually caused by a Schatzki ring. Okay, so smooth walls with a stricture in the esophagus is a Schatzki ring. Okay, so you need to see that there's a dilated esophagus here, and then the esophagus kind of resumes here, and in between there is a lot of irregular filling defects. Like the contrast, the barium is getting through, but you're not able to really see the full esophagus. And this is just a lateral view of the same thing. So this is known as a flea-bitten esophagus, and it's usually seen in malignancy, right? A malignant stricture is what will cause this. So a stricture with smooth balls, right? So smooth balls, stricture, Schatzki ring, but stricture with irregular walls, and filling defects, usually suggestive of a malignant structure. So this is another condition which can present you with dysphagia and regurgitation. So this is a Zenker's diverticulum, and it outpouches through the Killian's dehiscence. Something that MRCP likes asking is what is the muscle associated with Killian's dehiscence? So it's proximal to the cricopharyngeus muscle, right? So this is Killian's triangle or Killian's dehiscence, and this is where the esophageal herniation happens through, the diverticulum happens through. Okay, so this is also an esophagus. You can see again it's irregular, but it's not a stricture really. You can still see the entire esophagus. It's just that there are the little places where the barium is not going through. So what could this possibly be? So this is how varices look on the barium meal or barium follow through. So you should, has been very rarely asked, but because CLD and esophageal varices are such an important part of MRCP, I just thought you should know what varices look like. Okay, so what is this? You can see the esophagus, you can see these little irregular strictures, and then again the esophagus kind of becomes round. So this is something that is seen in eosinophilic esophagitis. You'll see these multiple rings that form. So now eosinophilic esophagitis is a fairly well recognized condition, and it's something that MRCP has started asking questions about. So you should know about it. Okay, so coming to other organs. So this obviously is the stomach, and you can see this appearance of the stomach where there are little filling defects where the barium is not going through. This is a typical leather pouch appearance. So you can see how this leather pouch looks. It looks a little flaky, right? That's the same appearance that comes here. And this is seen in CA stomach. It's also known as linitis plastica. Okay, so this is something that you should know. You're seeing the stomach, the barium is there, and then you can see the barium coming through here also into the duodenum. But there's a little gap here. This filling defect is suggestive of an obstruction. So this is a gastric outlet obstruction. It's a very typical cutoff of barium, gastric outlet obstruction. Can be caused by multiple things. It can be a tumor within the first part of the duodenum, or it can be a head of pancreas tumor. So any of these potential things that can cause it. It can be a CA colon, which can also cause it. Okay, so you see this little string between the stomach and the first or second part of the duodenum. This is called the string sign. And this is suggestive of a pyloric stenosis. This is also a gastric outlet obstruction. But yeah, this can also cause a gastric outlet obstruction like symptoms. Okay, so this is an image of a colon, and what you need to see is again this filling defect. So this is known as an apple core filling defect, and this is suggestive of a colonic carcinoma. Okay, so remember, let's look at this colon, right? So you see this colon, and the thing that is, this is obviously a diseased colon, but you can very clearly see these little segments, right? So any image that you look at, you will clearly see these segments of the colon. Let me just take you back to the X-ray of the colon. Okay, so this is not a great example. Okay, so look at this. You can see these little segments, right? So these are the haustrations that are there in the colon. But what happens when those haustrations disappear, right? They end up looking something like this. So what is this? So this is known as a lead pipe colon, and it's a dilated colon with loss of obstructions, and it's usually seen in ulcerative colitis. So what is this? You see, this is the colon, and then these little finger-like outpouchings. What do you think they are? So these are diverticuli, and they are usually seen in elderly patients. They are the most common cause of lower GI bleed in elderly patients. So if the history is telling you, elderly patient coming to you with lower GI bleed, they should do a colonoscopy to identify whether it's because of a diverticulitis or if it's because of CA colon. Okay, what about this? So you're seeing this, you have the rectum, the sigmoid colon, then the descending colon, and then you have barium going here, and it just completely stops here. So what do you think is happening here? So this is an intussusception, right? It's called a claw sign. It looks like this, where this part of the bowel has kind of gone into this part of the bowel, and it's gone so far in that it's kind of constricted its own opening. So, the barium is not flowing proximal to it. So this is an intussusception. Okay, what about this? You have this stricture that is continuously there, and then here you've got a large dilated colon. Again, you're not seeing any hostiotions. That means that it's like very dilated. So what disease does this remind you of? Where there's a stricture for like a big segment of the colon. It's kind of similar to achalasia cardia, but in the colon. So this is Hirschsprung's disease, and this is the transition zone of Hirschsprung's disease. Right? It can lead to toxic megacolon as well. Okay. So now I'm just going to go through some CT abdomen studies. Again, you don't have to be an expert at CT abdomen. You just need to be able to pick up like very obvious abnormalities. And most of the times, please don't get intimidated by CTs. Most of the times, you won't have to read the CT very accurately. You should be able to just read the question and come up with the answer. Even if they didn't give you the image, you will still mostly be able to come up with the answer. The only times when that's not true is there is some really big important finding on the CT, which you probably won't miss anyways. So what does this look like? It's a very straightforward CT. This big white thing is your liver. Then you have a little hypodense mass inside the liver. It's very homogeneous, very clearly demarcated. So this looks like a abscess. So this is a liver abscess. So kind of same thing. This is a huge liver. And then you have a mass, again hypodense mass with a nice rim around it, but it's very irregular and the margins are not, very clear. So this is usually how a hepatocellular carcinoma presents: hypodense mass with a rim and not a very homogeneous mass. Okay. Okay. So what do you see in this? You see this large liver, right? But are you able to see what the texture of the liver looks like? Look at this liver and what the texture is like, and then look at this liver. So you see these little nodules, right? So this is a cirrhotic liver with a nodular morphology, what we call macronodular cirrhosis, right? So we have an enlarged liver with a macronodular texture. So this is suggestive of cirrhosis. Okay. So look at this. Again, you have a huge liver. You've got multiple hypodense masses this time. So this typically is seen with metastasis, right? So hepatic mets present like this with multiple large masses, huge liver, and again irregular. So irregularity of margin usually suggests malignancy. It can either be primary or metastatic, but irregularity is something that you should pay attention to. Okay, so this part of it becomes a little complicated. So let's look at what we can identify. So this little structure here is the liver. It looks pretty okay. This here is the right kidney. This big mass on the other side of the liver is probably the spleen, and this here is the left kidney. So now you're seeing this little thing here, which probably looks like what is abnormal. What do you think is there in between the liver and the kidney, right? So this is the pancreas. And if you look at this is the tail end of the pancreas going in towards the spleen. And around the head of the pancreas, you've got this sort of blob, right? Which is not really well defined. It's kind of going everywhere. So this is what acute necrotizing pancreatitis looks like. So this part is the acute inflammation in the head of the pancreas, and this is the tail of the pancreas. Okay. Okay. So now look at this, right? Last time we saw, again, you have the liver, the spleen, you have the left kidney, you've got this inflamed pancreas, and then you've got this walled off mass here. This is much more regular. You can see the margins. So this is what a pancreatic pseudocyst looks like. So you can see the wall as well, right? Okay. So what do you think this is? Again, you've got the liver, you've got the right kidney, left kidney, got the spleen, you've got these. This is the pancreas, and you've got multiple calcifications that are seen inside. So this is chronic calcific pancreatitis. Okay, so what are these structures, do you think? Got two kidneys, got liver, got spleen just above the kidneys. These are adrenals, and if you see them as just being enlarged but no enhancement is seen, then it's likely an adrenal adenoma. If you see enhancement inside it, it could be a potential adrenal tumor, it could be adrenal hemorrhage. So that will all depend on what the case scenario is telling. Adrenal adenoma also, there will definitely be some changes that are present depending on what is being secreted. Okay. Okay, so let's look at the kidneys. So what are you seeing? So this looks like a fairly normal kidney. Look at this kidney. You see the kidney, you see the renal parenchyma, and then suddenly you see these black shadows. Black shadows on CT obviously signify air. So if you are having air inside the kidney and the urinary system, it's likely emphysematous pyelonephritis. So that's something that you should know. And MRCP loves asking questions about it. So you should also know the causative organisms of emphysematous pyelonephritis. Okay. So again, huge kidney, very irregular, right? And not homogeneous. So what do you think? This is a renal cell carcinoma. Okay. So again, you need to know what are the possible genes affected in renal cell carcinoma, what is the presentation, what are the complications of renal cell carcinoma, and what are the surgical options for renal cell carcinoma. Okay. Okay, so now look at this. Again, MRCP loves asking about this. We've got two kidneys, both of them are huge to the point where the liver, the spleen are like getting squished. And look, multiple cysts in both kidneys. So this is a autosomal dominant polycystic kidney disease. Okay, and so that's about it. That's around 30-35 images that you should know. And then after this, you don't really need to know any more CTs. Again, if you run into any other CTs that you're having difficulties with, please do DM me and we can talk about them. Cheers.